Okay, we've begun recording, so continue with the housekeeping. We also encourage everyone to freely use Zoom's engagement tools. For a virtual setting, it's nice to have chat, reactions throughout the session. You're welcome to use those. When our presenter opens the floor for questions, you can raise your hand by clicking on reactions and selecting raise hand. Additionally, be aware that certificates will be provided for attending today's session. So to receive yours, be sure to stay until the end and complete the evaluation, including your name. So to begin, I'd like to introduce our speaker for today, John Burns. John Burns is a person with lived experience and the executive director of the SOS Recovery Community Organization with peer-based recovery community centers in Rochester, Dover, and Exeter, New Hampshire, as well as a social enterprise restaurant, Folded Community Diner, in Somersworth, New Hampshire. John founded Families Hoping and Coping in 2014, a peer-based family support group for family members and loved ones of people with lived and living experience who use drugs. Thank you so much, John, for being with us today.
Thank you for having me.
Yeah, for sure. Just a little background on the importance of this topic and why it was chosen for today's discussion. Tertiary prevention strategies are essential components of a comprehensive AOD prevention and treatment continuum. These strategies focus on reducing morbidity, mortality, and system burden among individuals with established substance use disorders while supporting engagement, stabilization, and long-term recovery readiness. So the objectives today of this session are that as a result of this training, participants will be able to, one, identify key historical or conceptual shifts in tertiary prevention and connect those shifts to current roles and responsibilities. Two, name real tensions or contradictions practitioners are encountering and explore how peers are navigating similar challenges. And three, develop and use shared, clarified language to strengthen communication, alignment, and collaboration across harm reduction efforts. So we are well introduced, so let's get started. As mentioned, this session will be interactive. So we'll be using polls and breakout sessions to gather your perspectives and engage in meaningful discussions. So we'd like to get started with our first anonymous poll that Manna will present for us.
Good morning, everybody. We're going to start off with the first question. So what is your first thought when you hear harm reduction or tertiary prevention? And please, we're using Slido today, so you can participate by going on your computer or your phone to slido.com, and you can enter the code 3534238, and you can enter as many times as you'd like, or use the QR code, which is on the upper left corner. If anybody has any questions, please raise your hand and we'd be happy to help you. Saving lives, underfunded, helping undertrusted, keeping each other safe, yes. Reducing disease. Excellent. So as you see, the larger the text, that means the most people are kind of agreeing with it and putting in the same types of themes. So reducing harm and saving lives. Thank you. Give it one more minute. Fantastic. Thank you all for participating. I'm going to pass it over to John, and we'll start the presentation.
Great. Thank you, Donna. Thank
You're
you.
welcome.
Welcome, everyone. So, want to get started. We're going to do a quick breakout. We're going to put you in break. It's going to be very quick. You're going to be in breakout rooms for about 5 minutes, and we'll have a quick 5-minute discussion when you're done. And when you go into your breakouts, if you could pick somebody or volunteer somebody to come back and be your reporter. And we want to have you spend just a quick 5 minutes discussing these two questions, which are why do people use substances and why do people stop using substances? So we'll send you into breakout rooms if nobody has any questions and come back reporting out with somebody to report back out, and we'll have a little bit of a discussion on it.
Thanks, John. All right, I'm opening the breakout rooms. Everyone will get set to a room, and you can always use the chat if you have any technical trouble. See you very. All right, I think everybody's back here with us, John.
Okay, great. All right. So for those of you who are chosen as reporters, you can raise your hand in here and what kind of report out what some of your answers to why people use substances and why people stop using substances. Any volunteers? Christy.
I definitely used the wrong emoji there, but clapping for you already, John. For using substances, we said for coping, for some from trauma, for fun, to unwind, to help with pain, to escape from stress, to increase your confidence, because of a lack of connection, because of boredom, and for some drugs because of performance enhancing.
Okay.
And then do you want me to do the second question too?
Yeah, sure.
And then for why do people stop? We had for legal reasons, because they're exhausted from the cycle, for health concerns, because they've received therapy or treatment for their trauma, because of family or children obligations. And that's where it's off.
Great. Thanks, Christy. Anyone else? Any of the other groups? Or any thoughts on some of what Christy came up with?
Hi, John. I can't find my raise hand thing down there.
Okay.
But we had some great discussion, and for the first question about why do people use, some of what we talked about was to change the way that they feel, peer pressure, it feels good, and also because they're prescribed,
Sure.
you know,
Yeah.
and in ways why someone would stop, is to find a bigger purpose in life. The pain's a great motivator, to cause someone to stop, to provide connections, family obligations or to save a family, their health, to save their lives. They'll stop, or sometimes it could be even cultural or spiritual, like awakening, that could guide that decision to stop. So,
Yep. And I heard connections in there, which I think is a great point. So people might stop using substances for connection, but they also may be using substances for connection.
right.
So oftentimes what doesn't get identified and is often a barrier for people getting well is their connections. Because when we think of people who use drugs, a lot of them, very rarely do people use alone. For the most part, they use them with their peers. And oftentimes that creates, we have to look ahead. And when it's, if they're looking to make changes, that change might involve losing all their friends and all their connections, which can be a pretty terrifying thing. If you don't have strong family connections, if you don't have a strong group of friends outside of those you use with, like, what does that future look like? And that can be pretty terrifying for people. And they might not be willing to identify that, but oftentimes that's one of the areas we look at. And that's why we see a lot of in peer-based supports, why they can be so effective, because we can help them recreate and create new groups of connections that might be helpful. Any others from any of the other groups? Thanks, Kate. Yes, Eileen.
I think we had all of the ones that Kate and Christy mentioned. In addition, we said people use as a response to systemic injustice. And they also sometimes stop due to a change in living circumstances like housing or supportive employers or things like that, other supports.
So can you elaborate on the systemic injustice and what you mean by that?
I knew you were going to ask me that.
Good.
Okay.
You know me so well, Eileen.
Oh, I'm gonna ask Sam to elaborate on that because we kind of tucked it in at the last second.
Okay.
So
John, well, I'm definitely not like an expert to speak to this, but I guess I just think sometimes about factors in the world that create pain and barriers and challenges. And so, people can use for a variety of reasons, but I think sometimes we make it a very individual issue without taking into account the systems that might influence somebody's use.
Sure. No, that's a great answer. Thanks. Yeah, and I think like one of the things that comes to mind when I hear that too is we know we have a huge problem with housing, and we see a lot of, not everybody who's unhoused uses drugs. Not everybody who uses drugs is unhoused. But also when we look at, there was some research done not too long ago about the unhoused community, and it kind of brought on a conversation of which came first, the chicken or the egg, so to speak, because for a lot of people, being thrust into a situation where they're unhoused can cause drug use, or maybe it'll create a situation where drug use becomes chaotic or problematic. And then there's also the argument that people become unhoused because of drugs, because of their drug use. And both are true, but it's surprising the number that problematic drug use comes about because of the change in their housing status and the fact that they became unhoused. So it kind of, they both become very problematic in the relationship between the two. But oftentimes we don't think about the fact that being unhoused causes it as much as the drug use might lead to you becoming unhoused. So I think those kind of overlap with what you were saying. Any other thoughts or comments around this? All right. So I always ask these two questions because I think it's important if we're going to look at tertiary prevention and harm reduction. Oftentimes we don't think about the why, and like people use substances because they work. And they work depending on, there's a lot of different motivations for why somebody might use substances, whether they're licit or illicit. Like I drink coffee every single morning to keep me awake. It may not be thought of as an illicit drug, but it's still a drug, and it has benefits, and there's no chance I am stopping unless somebody finds a replacement that's going to wake me up in the morning. So we have to look at those things if we're going to look at people's motivation and how we might reduce harms and how we might be able to work with individuals in a space where we're meeting them at where they are at. All right, you can go to the next slide, Brooke. So before we dive into all this, wanted to kind of get through like defining what harm reduction is, what some of the principles are. We'll also talk a little bit about public health and prevention. Put a little shout out here and give credit where credit is due. If you had asked me what tertiary prevention was 5 years ago, I might have thought it was a pastry. So most of what I know about prevention, like I've learned, probably half of it I've learned from a good friend, Shannon Sweat, who works for Granite United Way, and I know a lot of you who work for her here. So in fact, me and her some of you may recognize some of these slides. We did a presentation together, a training on the fact that harm reduction is prevention. So you may see some of those slides that she created, I created in this presentation, but I just want to give credit because she's definitely taught me a lot about prevention and public health that I was never aware of coming into the space that I'm in these days with harm reduction and like really helps to break down some of the silos. So when we talk about harm reduction and define that, it's a set of practical strategies and ideas aimed at reducing negative consequences associated with drug use. And I think a really important part, and this is often really forgotten, is harm reduction basically came out of the HIV crisis back in the 80s. You know, and it was a social justice movement that came out of that whole situation, that whole crisis with HIV. A lot of it was led by the LGBTQ community. There was a lot of like Black trans leadership that led the charge with that. And oftentimes we get so focused on harm reduction and we think of it as just naloxone or safe injection sites, and there's a spectrum. But we forget the fact that it is still, and it always has been, a movement for social justice, because most of the policies and most of why we're at needing harm reduction are policies that were designed to harm communities of color and vulnerable communities. And so it's really important that we don't lose sight of that social justice piece whenever we talk about harm reduction. And it's built on that and a belief in and a respect for the rights of people who use drugs. All right, next slide. So these are the primary principles of harm reduction. This comes from the National Harm Reduction Coalition. And those are that, you know, when we talk about the principles of harm reduction, we want to focus on the health and the dignity of the people we serve. We want to make sure that our services are participant-centered, that it's not about what we want for participants, it's about what they want and making sure they have the autonomy and that we're empowering that autonomy to make their own decisions and determine how they want those services. It's about participant involvement. A lot of times we think about harm reduction and we talk about the fact that people might be 5 times more likely to go to treatment because of harm reduction services. And that's great, but it's not the intent of harm reduction. Like I would never build a harm reduction program with the intent of getting people into treatment. Harm reduction is about reducing harms, period. There's this really cool bonus plan that comes out of it where people are more likely to stop drugs and they're more likely to go to treatment. But that's not my purpose, because when we start to do that, we lose sight of the fact that people have the right to, you know, that people should have that autonomy to make that decision for themselves. So really looking at participant autonomy, looking at their own involvement, looking at sociocultural factors, because that plays a huge role depending on what kind of a culture you're working with. There's a lot of cultural norms that we might not be familiar with when we go into communities that we're not familiar with, and being mindful of that and being culturally aware. And then it's really about pragmatism and realism. So being pragmatic in how we approach it, being realistic. You know, we all remember the Just Say No campaign that failed so miserably. Wasn't very realistic that we can just go around and tell everybody to stop using drugs and that's what will happen. So we need to be realistic and we need to educate people versus try and force them into decisions they're not ready to make. So those are I could talk about this for a half hour, but we don't have time. So you can go to the next slide. And then I think when we talk about harm reduction and we talk about substance use, it's also really important to look at the fact that it's a continuum. So the vast majority of people who use any substance, whether it's alcohol, whether it's illicit substances, whether it's legal substances, there is this continuum. And we, as a society, especially in the United States, we tend to focus on the right side of this slide, on the heavy, chaotic, problematic use. We often forget that there's abstinence, there's people who experiment with drugs, there's occasional social use of drugs. You know, I think we've all probably been aware of somebody who might go to a party occasionally and sniff cocaine. And they seem to do just fine with that. And it doesn't become a problem and they don't end up moving into chaotic use. And that is true with all drugs. Sometimes we see these, even with heroin, we see these narratives that if you shoot heroin, not shoot, but if you use heroin, however you would choose to ingest it, You do it once, you're going to be addicted for life and you're going to have a substance use disorder. And it's just not true. So being mindful of that and being, that roughly, the data shows that 80% of people who use substances, including alcohol, do so without ever developing a substance use disorder. Not everybody who uses a drug or alcohol has a substance use or alcohol use disorder. And also being mindful of the fact that when we look at this continuum, realizing that for a lot of individuals, it's a refuge from suffering, it's a refuge from social losses. So it's a place where people have a lot of trauma, and that's not the only cause of it, but it can work as a very effective refuge from that. And so how do we resolve some of those issues as they become problematic, chaotic, and heavy? How do we reduce those harms? And it's the same thing with harm reduction. Harm reduction isn't just like one thing. There's a whole bunch of putting on my seatbelt when I get in the car is harm reduction. Naloxone is harm reduction. Medical medication for opioid use disorder or alcohol use disorder are both harm reduction. Abstinence is the most extreme version of harm reduction that you have out there on one side of the continuum. And then you can move to syringe services all the way to safe injection and safe consumption sites and overdose prevention sites. And even, in many countries, you have legalized heroin where you go for daily injections above and beyond like a methadone program. So there's this continuum and different organizations, agencies, different strategies come and dive in both on the continuum with substance use as well as the continuum of harm reduction. And I often say, people will talk about the relationship with recovery. Every form of recovery, every pathway of recovery is a form of harm reduction. Like one of the things that annoys me is when people say harm reduction is a pathway of recovery, and it's not. Recovery, if you think of the universe, you can think of harm reduction as the universe, and recovery is one planet in that universe, because everything that we do with recovery has some form of harm reduction involved, and it's kind of the umbrella above recovery or alongside it. So just kind of throwing that out there for some perspective on at least how I view it, and others view it differently, but that's fine too. Next slide, please. So as we define, now moving into public health and prevention, what is prevention? Prevention is the act or the practice of stopping something bad from happening, quite simply. Prevention is really about strengthening protective factors for individuals, reducing some of the risk factors in individuals. And that can be family, schools, community, society. That's a definition that came out of SAMHSA. And then a definition that came out of the World Health Organization is that prevention science focuses on the development of evidence-based strategies that reduce risk factors and that enhance protective factors to improve the health and well-being of individuals, families, and communities. So that's that intersection with harm reduction. When we look at prevention, these are some of the definitions of looking at public health and looking at prevention. You can go to the next slide. So there's also various types of prevention, which is really important. So when we look at primordial prevention, that is on the bottom of this pyramid, and that focuses on risk factor reduction. So that would be something for an entire population, and that's usually carried out through large social changes in national policy. Real quick, can anybody think of like a primordial prevention strategy? Anyone want to take a shot?
Universal health care.
Yep. Yeah, so that's great. Yeah, so universal health care. Things like public policy. So bike lanes are primordial when a city and urban planning puts together bike lanes, or the Clean Air Act. Those are all primordial prevention strategies. And then we move towards primary prevention, and that involves interventions to prevent an adverse health outcome from occurring. So nothing's happened. We want to make sure that somebody doesn't develop a substance use disorder. We want to prevent that. Oftentimes we target a lot of primary prevention gets targeted towards different populations, groups, and communities. The one we most often think of is youth, right? Because we want to address it before they become adults and end up with a problem, and kind of get ahead of it before it becomes tertiary prevention or secondary even. So primary is really that intervention that prevents the adverse health outcome from ever occurring. And then you can move to secondary prevention, and that will focus more on early disease detection to diagnose conditions early and promptly treat them to stop or slow progression and minimize impact. So a great example of secondary prevention, although I would say it straddles primary and secondary, but if you've ever heard of SBIRT, which is the screening for a brief intervention for treatment, that is used to kind of screen people to see if there's a substance use disorder or a high risk of developing a substance use disorder. So it has a little bit of a primary component, but oftentimes we will discover somebody moving towards problematic substance use using SBIRT screens. So there's different screening tools like that that can be secondary prevention. And it's really getting in there early and being able to address it before maybe, somewhere before it becomes regular use or problematic use, and addressing those factors. And then finally, you have tertiary prevention, which is what we're talking about today. And that really aims to lessen the negative impact of a health condition and prevent complications. So when we're doing harm reduction, it's tertiary prevention because we're looking at reducing harm, which will lessen the negative impact. So if we can work with somebody to provide them sterile syringes, they might not end up with an abscess or an infection or HIV or Hep C, and that is all a prevention strategy to lessen any negative impact of that injection drug use. All right, you can go to the next slide. So one of the things we often have challenges with when we talk about prevention, treatment, and recovery is looking at the social determinants of health, other community and system level factors that we can't ignore when we're discussing contextual factors associated with any major public health issue. So I would even say, like, one of the challenges that we often have with looking at substance use around as like a substance use disorder. So that diagnosis in the ASAM is very helpful for insurance and all of that stuff. Not saying there's anything wrong with it, but it often ignores social determinants of health. And it allows us to kind of look past and see it in more of a hyper-focused way, without looking at some of those bigger community factors that affect somebody developing a substance use disorder, and without looking at some of those contextual factors. And a lot of those challenges come with negative representations. They come with stereotypes and stigma. We see a lot of intergenerational substance use that if we don't pay attention to, it's like if we don't break some of those intergenerational things, then that becomes challenging. We have challenges with prevention, treatment, and recovery because of fear of legal consequences, right? Like we have seen this with prenatal. We have people who are pregnant who are scared to go get perinatal health care or prenatal health care because they're afraid that their children will be taken away because it's going to get reported to DCYF. We have people who don't want to talk about their drug use because they're afraid they'll get arrested. Great example of like a fear of legal consequences is we've heard these myths about of cannabis being laced with fentanyl. We know that if like you were to smoke cannabis, the burn point of that is going to burn off the fentanyl. It's not going to have any euphoric effect. And so there's never been any like real confirmations on toxicology with cannabis. And I have had physicians come to me and swear that the people that they're working with told them that they didn't use any fentanyl and that they only used cannabis and that there's no way it had to have been laced. And I was like, it's a felony. Cannabis is not a felony. Fentanyl is. They're probably not being truthful out of fear of legal consequences. So there's also a lot of misperceptions and faulty explanations about addiction and opioids. I gave one already that like if you touch an opioid once, if you touch heroin once, you'll immediately have a substance use disorder. And it's just, those things aren't true. Not to say that there's not some significant risks and that we don't want to address protective factors, just that there's a lot of misperceptions out there and faulty explanations. All right, you can go to the next slide. So when we talk about this, like I think one of the questions that comes up is why is there this double standard when it comes to substance use? When we look at public health, when we look at prevention strategies, we often hear people in the prevention world who are primarily in primary prevention, we often hear narratives of like harm reduction is enabling and we can't have it. Yet it's a public health strategy. And when we look at public health, there is pretty much no other public health strategy out there that does not engage in harm reduction. It might not be defined as harm reduction, but I often will give the analogy. I'm guessing most of us in this room use a seatbelt. And I don't think I've ever like met anybody who were like, good thing for seatbelts. Like I never used to drive recklessly, but now that I can put this seatbelt on, I can do like 110 down 95. And like if I crash, I got the seatbelt on, so I can drive more recklessly, I can drive faster, and and none of that would happen without my seatbelt. So it's a good thing they put these seatbelts in cars. Likewise, I don't think you'd find a football player who thinks because they have their helmet, they're going to drive headfirst into walls with their head and smash into it. Nor are they going to run, we talk about helmet to helmet contact in football. So all of these are harm reduction strategies. And, but for some reason, when we start to talk about substance use, things like providing a sterile syringe is enabling, and that is going to cause somebody to that as if they're going to stop using drugs if we didn't provide that. Or if it wasn't for naloxone, like we're reversing all these overdoses. And so that is sending a message to people that they can use drugs all they want. Like no one's ever enjoyed having to have naloxone used on them to reverse an overdose. Nobody who uses drugs ever is thinking, I'm probably going to use a little bit more today because I know there's this naloxone out there. And I probably won't die, so I'm going to use more today and take my chances. It's just not a reality. And so it's really a double standard. And when we look across the healthcare system, we wouldn't talk about withholding insulin because somebody wasn't paying attention to their diet. And okay, well, if you're not gonna follow the doctor's orders with exercise and diet, we're not going to give you this insulin anymore. It's enabling until you shape up. You're just going to have to take your chances. So I think this is an important topic when we look at those double standards and putting it in perspective. It just doesn't happen in other healthcare strategies. You can go ahead to the next slide. And then this is also a really important thing as we're talking about tertiary prevention and harm reduction, is also being aware of community readiness for community change. So there's all kinds of models on this. It's really important when you're looking at any sort of a public health strategy and implementing one, that we need to look at the degree to which a community is ready to take action on or address an issue. So what is this community readiness model? It was developed in 2014 by a group called the Tri-Ethnic Center for Prevention Research. It was out in Colorado State University. And it's partly based on it, for those of you who are familiar with the trans-theoretical model of behavior change, stages of change, so to speak. It's based in part on this. And so when we look at community readiness, understanding where the community that we're working in is ready to make changes, because if we get ahead of that, it's going to be really hard to make any changes with strategies around public health. You can go to the next slide. All right. So when we look at this model, there's stages of community readiness, and then there's dimensions of community readiness. So we see the 9 stages, and the bottom would be the least ready for a change. So if you've got a community who has no awareness at all about what harm reduction is, you have to kind of look at, well, how do I address that? Because they're not going to make changes. They don't even understand what it is. And then it's not uncommon as they start to learn, we see this denial and we see a resistance where they just don't understand it and they completely deny stuff that we know is true, and that this really strong resistance. our organization is facing this in spades as we try to relocate our center, right? If you've ever tried to engage with starting a program around recovery, substance use, harm reduction, especially harm reduction in the current culture, it's very challenging. Like, we had a planning board meeting for a new location that we're trying to locate in Rochester that lasted 4 hours. And it was 3 hours and 45 minutes of neighbors just getting up saying some of the most heinous, vile, untrue things that are not consistent at all with what our public health data shows. And it was kind of a lock up the children, hide them, because this organization's coming in and they're going to just destroy our neighborhood. And so a lot of that, when we look at stages of community readiness, they're at like an 8. So how do we affect some change there and bring around some awareness and start to move into like section 7, where at least they have some vague awareness? And how do we kind of look at how to do that? And then once you get some of that awareness, looking at pre-planning and preparation. You know, the city of Rochester kind of simultaneously is looking at restricting syringe services to a 1-to-1 exchange with a maximum of 5 syringes, and they want to not allow any syringe service to be mobile or pop up, and they can't be within 750 feet of a church, a playground, a park, a daycare, or a school, which basically eliminates 90% of the city. So how do we work around that? You know, how can we educate people to understand the harm? And that, like, most of this is because they are worried about discarded syringes, and all of those strategies would be the best possible strategies to increase improperly discarded syringes. So that's kind of an education and awareness thing to build community readiness to put a stop to that happening if we're going to do advocacy. And so then you get into, like, once you do that preparation, initiation, bringing about stabilization in the community, and expansion, and then community ownership. And then over on the right, we have the dimensions of community readiness. So the first part is like having a community knowledge of efforts. How does the community know about the current programs and activities? How do you educate them about that? What is leadership's attitude towards addressing the issue? So, like, what is city councils, or if it's at a state level, what is the state legislatures and the policymakers? What's the governor's attitude towards this issue? Because you're going to have some allies at that level. What is the current community climate? You know, there was 5 years ago, we wouldn't have had the resistance we're having right now. There's been a shift in culture. So we have to look at the community climate and what the community's attitude is, and then looking at what is the community's knowledge of the issue. It's often stunning to hear people proposing policies that don't know anything about the policy they're proposing. And so how do you provide that education and that awareness? And then what are the resources that are being used, and how could they be used to address the issue? So these are really critical as we look at tertiary prevention. If we don't have community readiness, then it's really difficult to implement tertiary prevention and harm reduction. And you can go to the next slide. So taking action really involves making sure that we determine best strategies, action steps. We want to form objectives and action plans to advance the community acceptance of harm reduction strategies. We want to be targeting specific audiences. You know, maybe we're not going to get the entire community on board with it, but maybe we have some key allies who can help us bring along people that might not normally be allies. So how do we target specific audiences? Like, why does the issue matter to individuals is a really important, and what are they willing to listen to and accept? And how can we address? You know, I always, like, if we can identify what the concerns are, that gives us a first step in addressing the concerns. If we don't even want to listen to the concerns, then we're not going to get very far. And then making sure we take into consideration the messenger and the methods of communication. I know that, like, there's certain spots where it turns out, like, I can be polarizing. So I bring along our deputy director, Maggie, to do this. She's much softer and gentler in her approach. And, like, you get up and speak this time, because, like, I'm just going to tick them off. So having that awareness and making sure that we select messengers that might not be the normal character that you might send in for an issue like this, and how do we mix that up? And then also assessing our existing relationships. So I might have a terrible relationship with a policymaker. It doesn't make much sense for me to try and bring them into a conversation. But I might know somebody who's really good friends with them and has a personal relationship, and maybe I can work through them for them to kind of have some conversations and get a better feel for where things are and use those opportunities to leverage trust and build trust. So just looking at kind of all of this and why it matters and what does this have to do with harm reduction, and it's really about the fact that, like, if the community's not ready for it, it's going to be really difficult to provide harm reduction services. So we have to, when we're looking at tertiary prevention, we have to look at community readiness, or we're going to be swimming upstream at all times. And you might anyways, but at least having this allows us a strategy to get ahead of it at some point. Go to the next slide. All right, so the next one is the impact of stigma. So we know that stigma is one of the biggest challenges that we face with both people who use drugs as well as the community when it comes to acceptance of harm reduction, right? Most of the stuff that we hear as reasons not to implement harm reduction are completely steeped in stigma. It's going to increase crime. It's, those people who use drugs are terrible people. We've created a culture where when we look at drugs are bad, and so everything gets associated with bad versus good. And that's really important when we look at how do we do some training around stigma so that we reduce the impact of it when we're looking at community acceptance. You can go to the next slide. So one of the biggest impacts of stigma comes from our language. And we still see it every day. I see it in bios. I see it in names. I mean, we see it in the names of federal agencies. There has been extensive research on stigma and language. We know that, like, they did a study around the word abuse as it relates to substance use. They did a study with a case study with the exact same case. They split up a group of behavioral health professionals, put one in one room, put one group in one room, put another in the other room. And in one case, they talked about substance use disorder, and they talked about an individual with a substance use disorder. And in the other room, they called that person a substance abuser. And they referenced anything around substance use as substance abuse. And then they kind of probed on what we should do about it. And this room of behavioral health professionals that we would assume would be compassionate, the one that used abuse, were more likely to say that person didn't deserve help, versus the other group who felt that that person deserved some support and that we should put together. So the result of that was basically that the simple use of language created a space where people who would be treating that person were willing and able to do more effective approaches to treatment and support than the other one. And so it would have, it impacts, we know from that research that language and stigma impacts the care that people receive. And we see this all the time. We see it in emergency rooms where we'll see there's some nurses and providers who are great. There's also some not so much where people are mistreated. So when we think about this, how does that word abuse perpetuate stigma when it comes to people who use substances? Because, like, what is abuse? When we hear abuse, we think of things like domestic violence. And then why is it important to use specific language when it comes to service provisions? So just looking at that and how we can address stigma. And we've learned a whole lot more since that one study. There's all kinds of research out there. Things like we've shifted from medically assisted treatment, and then we saw a push for medically assisted recovery, and now the more commonly accepted term is medication for opioid use disorder. And like that is very strategic, and that has a lot to do with language. And again, when I look at language, I often teach, like, I'm not there to be the language police, but being in this work, I want to model language that is not stigmatizing. So if you were to go through our website, you probably won't even see substance misuse. You will only see substance use. We're peer-based, so I don't use substance use disorder because a lot of people in the harm reduction community and people who use drugs don't feel like they want to be pegged as disordered. So we talk about problematic drug use, we talk about drug dependency, and we use that type of language because of the stigmatizing effects of some of the other language and because of the space we're in. You know, again, it depends where your space is, that language might be altered. So doesn't mean there's anything wrong with substance use disorder, just doesn't fit in what we do necessarily, unless we're moving towards a diagnosis, and we're not clinical, we're not doing ASAM assessments, so I don't need it as part of our language, or we don't. Next slide, please. So the impact of stigma, how do we reduce the spread of disease? You know, substance use, again, is the only health issue for which harm reduction isn't at the core. When we look at heart disease, when we look at diabetes, when we look at obesity, all use harm reduction as a core of their model. You know, health, diet, exercise, no one's cutting somebody off from their treatment for heart disease, diabetes, or obesity because they didn't follow the doctor's orders. All the time it's suggested that we should force people into treatment, and or like they don't deserve it because they didn't want it bad enough. So looking at, you know, again, we want to look at like the impact of stigma. When we talk about hepatitis C, we've been doing a big screening and a program with testing for hepatitis C. There's still doctors out there that want a certain amount of recovery and abstinence before they will treat hepatitis C in this state. It's becoming less and less, but we have to be very careful. We vet providers that will provide hep C prevention, training, screening, and that when we're connecting them to a provider for treatment, that provider won't stigmatize somebody based on their drug use, because we want to connect them quickly to treatment. So that, again, is nestled in stigma. And then, you know, we still see this with health centers, like it doesn't make sense why we have health centers that refuse to treat hep C based on some of the substance use. Those are kind of like antiquated approaches that are 100% not evidence-based and based in stigma. And then, you know, when we look at this, that impact of that stigma, you know, begs the question, if we're gonna reduce harm reduction strategies, we're eventually gonna have a major HIV outbreak. And I am always in awe of how long it took for us to legalize syringe services, that we didn't have one already. There's been a few smaller outbreaks, but we're actually fortunate. And so as we start to see the pendulum swing back the other way recently, it's very concerning that we could see a major HIV outbreak. You can go to the next slide. So looking at removing silos and advancing harm reduction as tertiary prevention. Now, one of the things that I talked about that training we did, that harm reduction is prevention. And I think one of the challenges we get ourselves into is when we look at this continuum of prevention, treatment, recovery, and harm reduction, is we silo all four of them separately. And I think it's really important we start to look at the end of the day, all four should be working in concert, and we should be looking at reducing silos and working together. There's nothing that pains me more than somebody who's involved in involved in prevention, that sees harm reduction as problematic. Like, how are you working in that space if you're not willing to educate people about a strategy that's based on public health? And, you know, and we see that all the time. Like, we see very specific programs that are very law enforcement oriented that won't acknowledge harm reduction as an effective tertiary prevention strategy. And you know, it begs the question, why, given the evidence? Go ahead. You can go ahead. So I just want to kind of wrap up. This could be a much longer training. But just looking at the current landscape in New Hampshire and how we address substance use. So we've come a long ways, and as a result of that progress, we've seen a big reduction in overdose deaths. We're still pretty far away from, in my opinion, an acceptable for something that's a preventable death. We shouldn't be, you know, like, until we're down to like none, every family still is important that it ravages. So just looking at the overall systems, we have public health networks, we have recovery community organizations, we have the doorways, we have 211, we have the recovery friendly workplace, looking at state government and advocacy organizations. We have, I guess I have to change that, Governor's Commission on Alcohol and Other Drugs, because they changed the name of that. We have the Opioid Abatement Commission, and then we have multiple other commissions. So, you know, looking at some of that current landscape and where the gaps are, and you know, I often say, how is New Hampshire currently being effectively served? And we could have a longer discussion, but we don't have time. But like, what types of harm reduction spaces exist in New Hampshire? I often think about the North Country, how much harm reduction is happening and available, and what's the accessibility and the barriers to that when we get into more rural areas, especially North Country. We have virtually no drop-in centers. There's very few drop-in centers in New Hampshire. Started to see some like low barrier shelters, but they're more emergency warming. They're not open every night necessarily. We have some syringe service programs, probably not nearly enough. We have some mobile harm reduction. Housing first, like, do we really have any true housing first models? And now we have the federal government with executive orders saying we can't have housing first, which won't help it at all because you can't get any federal funding nowadays for housing first. So they're undoing what little we had. And then like looking at active community members who carry naloxone, like, do we, we know that most overdoses are reversed by people in the community, especially people who use drugs. Do we have those communities fully equipped with naloxone and trained? We still regularly have people come through our doors, and if we ask them if they've ever been trained on naloxone, they really don't know how to use it. So making sure we're training everybody on it, making sure we're getting it in their hands, looking at how different populations are left out of spaces. This is incredibly important when we look at different cultures. And I'll give a great example that we've had no success, but we have an entire population of we have a pretty enormous Indonesian population in the Tri-Cities of Stratford County. I have never found any successful ways to integrate services for that community. We've been to Indonesian festivals with tables. It was as if we had the plague. I know that's a me problem, not a them problem, because we don't understand their culture, and that takes us being more aware so that we can provide services that will be useful to them. I have a lot of ideas on the reasons for that. It's just a different culture, and they keep it within their families. There's a lot of shame. It's a country that has the death penalty for substance use. So there's a lot of viewpoints on that are very different that we have to be mindful of when we try to provide services and programs and supports for that type of a community. But we have a lot of those types of communities around the country, around the state, and how are we serving them? Looking at the importance of peer-led interventions, how we're serving communities of color, how we're acknowledging issues of race and white supremacy and systemic racism in harm reduction spaces, especially at a time where diversity, equity, inclusion has become a buzzword that can get you defunded. So those are really important things to look at as we move forward around tertiary prevention. And then talking about how do we develop culturally specific services, all are really important. And you can go to the next slide. All right, so we're gonna do some breakouts and stuff, but does anybody have questions based on what I've presented so far that I can talk about or answer?
And if anybody would like to add their question in chat, please feel free.
I have a quick question that I could probably assume the answer to, but I really liked the community readiness slide. John, do you see communities like, I guess, backsliding? Can you see movement on both sides of both sides of the readiness scale over time?
I mean, yeah, I think I think people who I would identify as more aligned with how we view harm reduction have become more and more informed. I mean, I see it with like we've hired some people who've come from more of an abstinence-based background. And one of them comes to mind because we've had recent conversations where they've been approached by their circles of friends saying, what is going on with you since you went to SOS? It's like they've indoctrinated you, which we get a big kick out of because had so much more of an abstinence-based mindset and is now seeing a lot of the value of harm reduction and is fascinated by that, is like really found it valuable and helpful. And I mean, I think of myself, and when I came into this, if you had talked to me about a lot of the stuff I'm supporting and aware of and educated on now than I was 10 years ago, like completely different human being that I probably would have held my nose at over some of my views a decade ago. So yes, I'm seeing people who are aligned with it. continuing to be more educated, continuing to be more open to it. US is still like, even you go to Canada, we're probably more than a decade behind a lot of their viewpoints and a lot of the progress they've made, which is stunning to me. I mean, they're doing things like legalized, regulated supply of opioids and heroin. Like that people can go get a dose of heroin in Canada. Like we're nowhere near that in the United States, but it's a very effective. Switzerland's been doing it for a decade. Likewise, the other side of this is the people who are not aligned, who are opposed to harm reduction. It's getting more and more. When I think of the hearing we just had to endure, it was traumatizing. And it almost became like, I'm guessing most of those people had those same views 5 years ago, but there is now a culture where not only is it okay to say it out loud, it's almost celebrated. There were people using terms like riffraff and like throwing around addicts and talking about how their children would be harmed by us. And it was really nasty. And they were going back to their seats with a big smile on their face. And I was almost waiting for them to start high-fiving each other. It was almost like a mob mentality. And I honestly don't think we would have seen that 5 or 6 years ago. I just don't. I think maybe they might have thought it, but they wouldn't have come up and spoken so proudly of just dehumanizing people, like just really being nasty about people who use drugs and people who are unsheltered. You know, it was really traumatizing for a lot of our staff to sit through. So I don't know if that helps answer your question, but I'm seeing it on both sides. It's kind of not neat. It's not great for those who aren't aligned. And I think we've seen executive orders that have banned harm, that are basically trying to get rid of harm reduction. We're seeing a lot of the CDC stuff and things like that scrubbed off of websites, the research and the literature and the science that supported syringe services. You can't find those documents on CDC websites anymore. So, any other questions? And if any of you disagree with stuff, like I welcome that dialogue. Like I'm always open to people who feel a certain way and might be opposed to some of the stuff I said and challenging that. Like I totally respect that people have different views. I think we can walk away from conversations disagreeing, and that's fine, as long as we're respectful with each other. So if there's people that have thoughts, comments, questions that might be in opposition to some of the stuff they've heard, please, by all means, raise your hand and let's talk.
John, do you have a go-to resource for like safe language? I know that like language is constantly evolving, and it's something that at RFW we try to keep an eye on and like make sure we're using person first language and like the correct terms that aren't dehumanizing or discriminating. Right. But I don't always know where to go to like keep an eye on that and
Right.
Yeah.
No, it's hard because SAMHSA still has the word substance abuse in their name.
Right.
National Institute of Drug Abuse. Like we have all these like federal and state agencies using the word abuse.
Right.
And then, here in New Hampshire, like I disagree with substance misuse.
Mm-hmm.
I feel like that's a bad versus good. Like it's kind of a snarky comment, but I never misused drugs. I used drugs exactly the way they were intended to be used. And they were very effective till they weren't. If anything, they misused me. But we have substance misuse prevention is the title. We had David Waters put together legislation last year where he removed, like I had big discussions with him about removing misuse. He did. Legislators lost their minds over the fact that he had substance use because it wasn't clear enough that it was bad. And so that legislation would have failed had he not put misuse. He was forced to put that back in there because he's like, John, I cannot pass this legislation without misuse.
I believe it. Yeah.
Right. So just simple things like that. So it's really, and I think it's evolving too. Like, we shifted a whole program at Goodwin Community Health to medically assisted recovery. And then we were like, well, that doesn't make sense either. We should be using medication for opioid use disorder.
Mm-hmm.
So I don't have one resource. I kind of have my own thoughts. And a lot of that has also been informed by, like, I always freely use substance use disorder. And then as we got into harm reduction, the realization that, like, that conversation around disordered and
Right.
Like there's a lot of people in the harm reduction community that don't even agree with the disease model. And at the end of the day, it doesn't matter if you agree or disagree with it. But like, let's not polarize people. So I try to find like language that just won't polarize anybody that is accurate. So, drug dependency, you see a lot in our language. If you're a provider, I don't think that's probably the best way you should be using substance use disorder because it's like it's an important part of like insurance billing and things. So the quick answer is no. But we do have, like, there are some tools which I think most of the RFW has with some of the charts that have been created over the years.
Yeah.
I mean, I'd be certainly willing to sit down with RFW2 and look at developing some more to kind of look at those different angles and present
Yeah, the team
that
talks
devil's
about
advocate of like, well, there's also all this view. And,
right.
and that can be considered.
Great. Thanks.
Yep. Anyone else? How are we on time, Nana?
We're doing well. We're at
Okay.
12:37.
Okay. And so we're supposed to be moving into the breakouts again, correct?
Yeah.
All right. So we have a couple big discussion questions. Brooke, did you want to introduce those or you want me to? I
Go
don't
for it. Go for it.
want me to. Okay. So we're going to do a couple breakouts here. You'll have again 5 minutes in your breakouts, but we're going to have about 10 minutes for discussion. So let's again assign somebody to be a reporter and we want to get some good input. But this first question for you to consider, and we will leave this slide up in the breakout rooms, correct, Brooke?
That's right.
All right, so you'll have 5 minutes in your breakout room. What harm reduction strategies are communities most ready to support today, and where do you see resistance or misunderstanding still limiting progress? And then what has helped move the needle in places where harm reduction has gained acceptance? So it's kind of a two-part question. So we're going to give you 5 minutes in your breakout rooms. Come back and we'll have a 10-minute discussion on this question.
All right. Okay, everybody is back.
All right, who are our reporters and what did you come up with? Have I lulled everybody to sleep?
I tend to be a first talker, so I try not to be, but I will share. We definitely could have talked a lot more. I think we all agreed on that Narcan training can be a good way to ease people in
Yep.
to harm reduction strategies. It's, you can equate it to like CPR or or Advil, like a medication you'd find at CVS, because you can find it there. There's still a lot of resistance and misunderstanding with needle exchange. A lot of like fear and stigma around that. We started talking about test strips and how some resistance can come from like not knowing where to get something or not knowing how it works. I did think about with test strips, in like social situations. I sometimes culturally we may think harm reduction strategies are only for this like small population of people that we have in our mind. That's a stigmatized image. But I don't know, you could bring test strips to like a concert, music festival, and when your friend realizes they can test their own drugs, then they might be more likely to support it for someone else who's using a different drug.
Yeah. And one of the big pioneers of drug checking in the United States came out of dance festivals. So there's an organization called Dance Safe, and like probably the biggest drug checking kind of culture that was created was them setting up tents at huge music festivals. And that's really like testing, things like Molly to make sure that it's actually Molly, which it almost never is. So there was also like really drug checking came more from that, I would say, than what you might think of the traditional harm reduction community.
Yeah.
So
Yeah. So there's a lot of like privilege and, oh, I can use this for myself. Well, then I want to support it for others.
Right. Right.
Yeah.
Thanks. Christy.
Yes, we said very similar. We actually noted Narcan and kind of how it's evolved in the state and become become kind of more accepted because of education around it. I do remember maybe 10 years ago in Manchester, where the health department wanted to talk nothing about harm reduction and enabling folks in the city. And they really have kind of like turned around, at least on the Narcan thing, maybe not so much on the needle exchange, but I mean, it just taken a long time. But and now they really like promote it, and a lot of that just has to do with like education around it and like really what are we talking about here? We still go in and talk to business leaders that think having Narcan on hand is a needle, a syringe type thing that, where they stick it into your heart and you start someone's heart back up and then you have to do, all of this stuff. And then when we explain it to them, they're like, oh, well, why wouldn't we make sure people are trained in that? Like hopefully we'll never have to use it, but like good to have it on site or if people, need it. So,
So it's
um,
not Pulp Fiction, is what you're saying.
yeah, yeah. Yeah, or I use a Grey's Anatomy example when I'm talking about it. But yeah, so we feel like that it's all stigma reduction and like also recovery notoriously has not been funded to like really record data about what works and what kind of things help folks. So we're seeing more data out there. We're seeing a reduction in overdoses, which so that's kind of what we talked about there for kind of moving the needle very, very slowly.
Yeah. Yeah, and we were making a lot. I feel like we were making a lot of progress, and it's really digressed over the last year or so. It's going in the
Yeah.
opposite direction really rapidly. We just had to testify. There's a bill in the state legislature that would defund any program that distributes any drug paraphernalia. So basically every SSP, and it would make us like for like SOS, it would make us ineligible for all the money that covers our recovery supports just by handing out syringes. We would automatically be ineligible for any source of funding.
Yeah, it's
So
unreal.
I just spent the day up in Concord last week testifying around that one. So hopefully we can stop it. That was a good turnout for it, but
Yeah, yeah. I think people are not scared to promote their kind of their hatred of others, their dehumanization of people that aren't like them. I don't know, but it's
and honestly, it really focused on improperly discarded syringes again. Like
mhm.
that seemed to be the intent of that bill, which I'm just like, this is going to have the opposite effect.
Yeah,
The one in Rochester would deny the use of drug disposal bins in public, which is one of the best public approaches to improperly like there's all kinds of research around it. But anyways, all right. Any other groups that haven't gone yet? Haven't spoken? Should be one more. Who's got another reporter? All right. No one else. We can move to the next question. All right. So the next question, we're going to do the same thing, put you back in a breakout for 5 minutes. How should we assess a community's readiness for policy or practice changes related to harm reduction, and what role should advocacy play at different stages from early education to policy change, and who needs to be at the table for advocacy to be effective? So we'll keep this up again. We'll put you in rooms for 5 minutes and then come back and discuss.
All right, here we go. All right, everyone's back, John.
Okay. So what did we have? Any thoughts, comments, feedback on your discussions around this question?
I could go for my group because Christy's done so much speaking.
Okay.
So we were thinking, how should we assess? We were talking about focus groups, coalitions, even having like town meetings where potentially we could have speakers for those that have experience in harm reduction, how it kind of changed things for them. So kind of getting the word out there, educating, the community members. as far as this one was a little tricky as far as what role should advocacy play at different stages, because we were thinking it should be a huge piece in every single part of it, all the different stages from that early education all the way to the policy change.
Mhm.
And then as far as who needs to be at the table, we really said everyone. But if we had to be more specific, policy leaders, we want youth vote in there, the actual community members, like the residents of the town, the people who run businesses in the town, like really it should just be everywhere. People in the field, the said field, things like that.
Right. All right. And then how do you get audiences together for that?
Mm,
Because that's always the tricky part, right?
mm.
Uh,
Offer food.
yeah, food definitely. I would agree with that. Yes,
Yeah.
food is definitely like the number one way to get people to show up. But
Yeah.
I think that we always run into that challenge of holding events like this where it becomes an echo
Yeah.
chamber of, well, I don't need to speak to everyone here. I'm like, you're all my friends. I already know you all support this, and you're just coming out to support it again. But how do we get the people
Mm,
who aren't engaged, who need to hear it, is always I think the harder challenge. Um,
mm,
and then I think it's really important that we look at the people who are using drugs and making sure that they have a voice. I often sit at tables that I'm invited to, whether they're like commission or task force groups or whatever. And I'm like, I don't know what it's like. I don't know what somebody who's 25 living in the woods in a tent right now using drugs needs. I have some ideas, but like, why don't we ask them? And so I think that's also an important piece, but also not doing it in a way that doesn't exploit them and that is mindful of some of the challenges of advocacy around that. So, one of the things we do as an organization is we hold them periodically. We do what we call advisory boards, and we invite our participants to sit down and tell us what's working and what's not. And then, fun fact, people freak out that we do this, but we pay them $20 cash. We don't give them gift cards because I want to respect their autonomy. And if I don't really care what they're using the $20 for.
I love that.
So I see a lot of organization, and sometimes that's challenging with grant funding. Like if you've got a Department of Justice, that's strictly prohibited. But at the same time, like too often I see organizational views of that being like, we're only going to give them gift cards to so and so store and make sure it's not a place that sells cigarettes either.
Mm,
I'm like, you got to be kidding me.
mm.
Like, is that really what we need to focus on right now? Let's give them the autonomy, to make decisions.
Yeah, having the population at the table is so important, and their voice. I mean, this years ago in prevention is my background, but um, we would do a lot of things around prevention for youth, but we had no youth around the table. And,
Correct.
for
Right.
a long time, that's how it was. It was very top down, and there was no youth
I'm
voice.
just gonna say that I'm gonna check out.
So it's huge. You need the population there that you are trying to, um, move along and help.
Right. And what we've found is it's real. Oftentimes we do it, and they're like, "You didn't have to pay me. I was just honored that you actually asked my opinion." But too often I look at some of the tables that I'm sitting at, and it's very confusing because I'm like, how many of these people actually have any clue what the people they're serving need? And so, so I think when we look at advocacy, like making sure that we're inclusive of people who are actually impacted by this stuff, as well as community members, just in general.
Yeah, and not tokenizing though.
Yes.
That's
Yeah.
another thing too, is
Yes.
you see some prevention programs even still do that today. Like, oh, but we have a youth representative, but they can't vote in
Right.
anything. They don't really have a voice or a say. They're just kind of there, right?
Right. Yep.
That doesn't help.
Right. Any other discussions on this question? Any other things come up in your groups?
Ours was similar to what folks have said. And in addition, another piece on assessing community readiness. Going to a city council or a town select board meeting when an like something that you have no stake in is not on the agenda, to just like be a fly on the wall can give you a pretty good sense of what their priorities are, and who matters to them, what matters to them. It can be, you know, not feel great sometimes, but you can learn a lot.
Right. Yeah, and as like, I mean, we started to do this, invite people who may not be looked at as allies, go grab lunch with them at that policy level. You might have a very uncomfortable lunch where you agree on absolutely nothing, but you can still try to find some common ground and at least get a better understanding of where they're at, and see if you can't take some smaller bite-sized approaches to some of the things they might be more accepting of that maybe they've never even heard of. For us, we always faced the reality that for the most part, the community has no idea all the stuff we do behind our doors because they hear syringe services. So to half the world, which often turns into people thinking that we're a safe injection site, which is just insane. Like I've had police officers tell city councilors like, "Oh, I don't support that place. They have a secret room in there where they're letting people inject drugs." And I'm like, "What? Like, where did you get that?" "Oh, the police told me that." And I was like, "No." And I've had to go have conversations with chiefs of police saying, like, you realize that's not real, right? So things like that, I think you can get a lot out of just sitting down with people who are not your traditional allies, if you can get them to, which can be a challenge too. I have a lot of unanswered emails of city councilors that I've been begging, like, will you just come to lunch with us? Can we just like, I don't care if you agree with me or not. I just want to have lunch with you to talk. So, but same thing. Good news, bad news about New Hampshire is we have like 4,000 state representatives, and it's complete chaos. And so it's hard to have a lot of influence with any one of them. But the good news is we also have like 4,000 representatives. I mean, I'm exaggerating, obviously, but most of them have their phone numbers on the state representative website. Like you can literally call their cell phone. And so there is an accessibility advantage that you could, unfortunately, every town of 9,000 has like three of them, but you could call all three probably tonight and probably talk to two out of the three. They're probably going to answer their phone, has been my experience. So it does give you some access.
I feel like that's shifting a little bit with folks lately, or the past few years maybe, where they just have an agenda that they're following and they aren't really representative of the community that they're serving, or they don't want to hear it.
Yeah, no, that's true.
So that's really challenging.
Yeah. And I've found the flip side of that too, where I know I can think of one who's an ally, but said point blank, I've looked at the research you gave me, and it was kind of based in California, so I don't know if that applies to New Hampshire. And also, like, even though I kind of lean your way, like my constituents don't, so I have to vote. I have to kind of go against and support one-to-one exchange because that's what my constituents want. And I'm like, which creates that question of like, so public health is less important than
yeah.
your uninformed constituents like opinions, like because it's more important to get reelected. Like I don't get it, but that's an ally. So what do you do with that? Like I can't come out and say what I want to say. But
Right.
any other thoughts or comments on this question? All right.
Yeah, sorry, John. It's Kate again.
Oh, go ahead.
I'm having issues with that raise the hand thing. Good stuff here. And, we also talked about how like going in and kind of like reading the room and sitting back and listening a little bit, and how Ellie mentioned going into, a meeting and just kind of listening and see where they're at, see what the temperature is about this topic. And, education, 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 and how important it is for someone with lived experience or success stories, like how important their seat is at the table. And also, what was the other thing I was going to say? Oh, I mentioned that you changed my whole thought process on harm reduction 2 years ago, because coming from an abstinence-based recovery program, I didn't understand it. I saw it as enabling or whatever the whole, and boy,
Right.
has my whole thinking on this has changed thanks to you at one of
Thank you.
your talks, saying that harm reduction is keeping someone alive long enough till they can find recovery.
Right.
And like that sold it for me. And so I can't tell you how many times I've shared that quote from you,
Right.
to help, you know, other people. Like, just open your mind, have a little bit of open-mindedness about things, and not to, like, we don't expect everyone to go from like no understanding to like 100% in. Like, we would love for that to happen, to have that, I'm all in, I support this, what can I do to help spread this, information, this news and importance. But like, to at least start, like, open that door a little and continue these conversations so that that door opens wider and wider and wider. But I did like, found interesting your comment about the different events. Like, how do we get the people who are never there? Like, so many events we go to, like you said, it's all the same people who
Mhm.
who understand or want to do this. And how do we get those who in the communities who aren't regulars at these meetings? Like, how do we get the general population or
Right.
community there?
Yeah. Yeah. Well, thank you.
Yep.
Appreciate that feedback.
Yep.
Any others? All right. I'll turn it back over to Hannah and Brooke.
Thank you, John.
Thank
That
you.
was excellent. So here we have contact info if there are more questions. We really appreciated your guidance, John, through this important session today. And also a huge thank you to everyone for contributing value with all your participation. It was excellent. So before we close the session, we just have a few announcements. You're welcome to visit nhtac.org to view past COP recordings and resources. And I'm putting the link in the chat to the certificate. It's also here on the screen, or you can QR it. Please be sure to get your certificate today by completing the brief evaluation. Be sure to include your name in order to receive the certificate. So finally, we want to say thank you to our planning committee members for their time and efforts working on this series related to tertiary prevention. Please keep an eye out for the next webinar, which will be held in April. And thank you again to all. Have a fantastic day.
Great. Thank you all.